Good evening, everyone. I welcome you all to the ICRI Radiology Teaching Program. I request the organizer to kindly begin the proceeding. Over to you, Sikandar sir.
Good evening and welcome back everyone to Women's Imaging session. And today is the last day of recap session of Women's Imaging. So I welcome today's speaker, Dr. Anuradha Chandramohan ma'am from CMC Vellore, and I welcome our coordinator as well as moderator for all our Women's Imaging session till date, Dr. Rupa Ranganathan ma'am. Welcome you. And before handing over to you, I request all the attendees to please make a point to subscribe for the next year's session, which is starting from the 1st of February. So don't wait till 31st January so that you will not be able to attend. So it's hardly takes 2 minutes, less than 2 minutes to register. And those who are already registered and subscribed this year's will be very easy. Just you will directly land up in the payment portal. Others who have not yet registered, please do register by registering, having your all credentials related with IRA membership, because membership number, your email ID and your contact number are mandatory for that. And even your medical council, state council name is also important. So with this, I welcome you all and I hand over session to Dr. Rupa ma'am. Over to you.
Good evening, everyone. As Dr. Sikandar said, today is the last session on the ICRI Women's Imaging Subspecialty. Today's speaker is Dr. Anuradha Chandramohan, and her area of expertise is onco-imaging and abdomen and pelvis. She has got several awards and credentials for her credit, and she has also authored and written book chapters of 72 articles. And she has the recent credit to her is she has received the ICRA Onco-Imaging Award for her best scientific work in onco-imaging for the year 2020. And today's session will be on the Adnexal mass, and it will be a pure case-based review as per all the other revision sessions. Over to you, Dr. Anuradha.
Thank you very much, Rupa, and thank you, ICRI IRA, for this opportunity. Let me just share my screen. Okay. Very good evening, everybody, and thank you very much for listening to this today. So what I've done today is it's a case-based review, but I've grouped the cases in a particular fashion along the theme of the mimics in gynae imaging so that there can be clear take-home messages. And I've also put them in a particular order so that it's easy to adopt some of the points that we're going to discuss. So let's move on to the very first. So in this 29-year-old female patient, I've shown you some MR images. And this patient had presented with heavy menstrual bleeding. I've shown you T2 sagittal image, T1 fat suppressed image, high V value diffusion weighted imaging, and ADC map. I want you to think whether this is a typical or an atypical fibroid. As you think about it, let me just show you a typical fibroid. I want you to drag your attention to this mass, which is making a claw, which is clawing the adjacent uterine parenchyma, telling us that it is arising from the uterus. And if you notice the signal intensity, it is similar to the skeletal muscle along the posterior abdominal wall, and you can see the skeletal muscles anteriorly as well. So why do we have the signal intensity? We know that the actin, myosin fibers, and the rich collagen in the skeletal muscle is what gives this T2 shortening effect to the muscle. And similarly, we know the most common neoplasm in the pelvis, that is a leiomyoma, is made of smooth muscle. And so the signal intensity matches that of the skeletal muscle. We see this kind of signal intensity in about 60% of patients, and this is a typical fibroid. What I've shown to the left is another fibroid. We know that this mass is arising from the uterus because we can see these bridging vessels. So this bridging vessels, when we see, it's called the bridging vessel sign. By bridging vessel sign, we mean that the vessels in the myometrium course through the plane between the uterus and the leiomyoma, and it supplies the uterus. So this vessels, when it's visualized, it's called the bridging vessel sign, and it tells us that this mass that we're seeing in the pelvis is arising from the uterus. So with this, let's see more example. This 29-year-old female patient was treated for infertility and was referred following an attempted adenomyoma fibroid excision. What is shown here is T2 weighted sagittal and coronal images. And I want you to think whether the diagnosis is one of these. Is it an intramural fibroid? Is it an adenomyoma? Or is it an atypical fibroid? Is it a leiomyosarcoma? Is it a rare Mullerian duct anomaly like an ACM, that is accessory cavitated uterine mass with endometriosis? The signal intensity of this mass is mildly T2 hyperintense compared to the myometrium, and there is heterogeneity in the signal. And eccentrically, you can also see a focus of hemorrhage and area of cystic change. So let's move on to show you the diffusion weighted images of this patient. The diffusion weighted imaging showed that there was a low signal on the ADC map, bright on high B value, showing that it's showing restricted diffusion. So we also notice that mass that we're seeing is solitary, and it has an ill-defined nodular kind of, does not have a nodular margin that we can perceive, but it's an ill-defined margin. There's intermediate signal intensity. It's heterogeneous, and we see an area of hemorrhage, and it's showing restricted diffusion. And this was a leiomyosarcoma. Okay. How about this mass? This sagittal T2 weighted image shows again a large solitary mass with a nodular margin. It's intermediate in signal intensity, which means it's brighter than the muscle, and it's heterogeneous. So this turned out to be again a leiomyosarcoma. Atypical fibroid is a spectrum. It could be anywhere between a cellular fibroid, it could be a stump lesion, which is stromal tumor of undetermined malignant potential, or it could be a leiomyosarcoma. So this was a leiomyosarcoma. Let's show you another example. This is a 43-year-old patient with abnormal uterine bleeding. I've shown you sagittal and axial T2 weighted images and diffusion weighted images. Again, we notice that this is an intermediate signal intensity, almost a cauliflower-like growth coming off from the fundus of the uterus, and it's intermediate in signal and showing restricted diffusion. Solitary with nodular margin, intermediate signal, heterogeneous, restricted diffusion. And I've not shown you hemorrhagic necrosis. And the ADC value was less than 0.9. And this turns out to be a stump lesion. Another example, this 42-year-old female patient was had presented with an abnormal uterine bleeding again, and was operated by a general gynecologist, and in the theater found this mass to be extremely vascular. The patient bled profusely on the table, and the surgery had to be abandoned. Again, when we looked back at this MRI at the MDT, we noticed that this was reported as a fibroid without a classifier, but a close look at this lesion showed that this is solitary, it's large, it has a lobulated nodular margin, it is intermediate in signal, it's mildly heterogeneous, and it's showing restricted diffusion. And this turns out to be a stump lesion. So finally, this patient went back into theater following the angioembolization, and this tumor was removed. With that, let's move on to see how many percentage of leiomyomas which undergo hysterectomies, presuming to be benign leiomyomas, turn out to be uterine sarcoma. It's about 2 in 1,000. We know leiomyomas are extremely common. So all of us in our practice are likely to come up across the situation where what we thought to be a leiomyoma, what the patient was clinically suspected to have a benign leiomyoma, but at surgery turns out to be a uterine sarcoma. And uterine leiomyoma itself can undergo malignant transformation, but that's extremely rare. 1 to 8 out of 1,000 will have a malignant transformation. Why is this important? If we do a morcellation and myomectomy under laparoscopy, and it turns out to be a uterine sarcoma, these tumors are going to be quickly disseminating into the peritoneal cavity, and they will have not only a quick recurrence, but the overall outcome of that patient will be very poor. And that is the reason why it's very important to put a classifier in front of the fibroid and say whether it's typical or atypical in our reports. And what happens when we do a morcellation of an atypical fibroid, which turns out to be a cellular fibroid? Again, there could be dissemination of leiomyoma, and there is also a chance of parasitic leiomyoma in about 0.9%. This is what the literature says based on these two meta-analyses. So let's go back to our index case. Is this a typical or an atypical fibroid? Let's take a closer look at the signal intensity. It's intermediate. There is a hemorrhagic focus, and it's showing restricted diffusion. So this is indeed an atypical fibroid and turned out to be a cellular fibroid. And it was well defined, unlike the previous examples, did not have a nodular margin and was more homogeneous in nature. And this turned out to be a cellular fibroid. With that, let's move on to stories of the fibroid. I've shown you an example of a CT scan where there is a large cystic mass arising from the uterus. We can again see the clawing and the endometrial cavity is displaced. It's to the left of the uterus. We can't characterize this any further on the basis of a CT image. And when we look at the ultrasound image, we see these recurrent shadows, and there's a bit of heterogeneity, and that's all we can say. We can only call it a fibroid. We can't say anything more than that on the basis of these two images. But with MRI, there is scope for so much more. So I've shown you T2 sagittal image, T1 fat suppressed image, and diffusion weighted imaging. And what we see here is an image of a young patient who was on oral contraceptive pills and came with lower abdominal pain. And what we see here is a very dark rim, outer rim of the lesion is extremely dark, T2 markedly hyperintense. Center is a little bright and heterogeneous. T1, we're seeing hyperintensity. And on diffusion weighted imaging, we're seeing facilitated diffusion. Bright on ADC and nothing much. It's similar to T2 on high B value diffusion. So this is a red degeneration of fibroid, which is the highest incidence of red degeneration is seen among pregnant women. It can be seen in about 8% of pregnant women. But among the entire garden variety of leiomyomas that we see in our practice, about 3% of them will turn out to be a red degeneration of fibroid. Unlike the classic teaching of pregnancy being associated with red degeneration, there are also other causes for red degeneration. One I've already said, patients on OC pills can have red degeneration. Other extreme is the postmenopausal women on hormone replacement can also come with red degeneration of fibroid. That is something to remember, and not to call something like this in a postmenopausal woman as a sarcoma. And the thirdly, after uterine artery embolization, again, because there's hemorrhagic necrosis of the fibroid, there can be red degeneration of fibroid. This is an example of a cystic degeneration of a fibroid. This is a broad ligament fibroid, again showing you the bridging vessel sign in the point of maximum contact between the uterus and the mass. And within this large, predominantly hyperintense mass, we see T2 dark areas. So when we see these lakes of T2 hypointense tissue, which is similar to the skeletal muscle in signal intensity, that is reassuring. So those kind of lesions are going to be benign, and this is a cystic degeneration of a broad ligament fibroid. Let's go on to a more interesting example. This is a patient who is nearly premenopausal, about 49-year-old female. She came asymptomatic and was found to have a mass in the lower abdomen, and imaging in her showed this kind of a large single fibroid in the posterior wall of the uterus. A closer look at this fibroid showed T1 hyperintense area, which got suppressed on a fat suppressed image. It means it is a fibroid containing fat. So this is a very rare type of degeneration. It is a lipomatous degeneration of a fibroid. Let's take a look at more interesting images of the same patient. Axial diffusion weighted imaging shows a T2 dark effect, means with diffusion there is no restricted diffusion. High V value diffusion, it shows a dark lesion. And if you look at the ultrasound, this picture is very classic. There's a peripheral rim of hypoechogenicity from the myometrium that is normal in the uterus. And the lesion, because it has fat, is very hyperechoic. So this is a lesion that can be mimicked as a dermoid. And that is why this patient underwent a MRI to characterize this mass. And it turned out to be a lipomatous degeneration in a fibroid. Degeneration can also be with calcification, and this type of calcification, amorphous kind of calcification, can be seen in about 4% of fibroids. And this is the mucoid degeneration. This is less common, about 4% again. 4 seems to be the magic number with fibroid, and mucoid degeneration can in a submucosal fibroid. You cannot differentiate this lesion from a leiomyosarcoma of the uterus or endometrial stromal sarcoma of the uterus. And this lesion has this kind of hyperintense myxoid matrix, and in between you can see these linear hypointense lines, and that is because of the smooth muscles which are interspersed within the myxoid matrix. So this turned out to be a submucosal fibroid with mucoid degeneration. But when we see a lesion like this, you have to give a differential diagnosis of a submucosal fibroid with mucoid degeneration or an endometrial stromal sarcoma. And this patient needs to definitely have a biopsy before going on to surgery. This is an example of actually a endometrial stromal sarcoma to show you the similarity between the appearance of the previous example that I showed you and this patient with an endometrial stromal sarcoma, which looks very similar, a polypoidal large growth filling the endometrial cavity and extending into the vagina. And this patient had, again, a similar appearance compared to the mucoid degeneration, and it's hard to differentiate the two. And this 22-year-old with endometrial stromal sarcoma underwent chemotherapy to downsize the tumor before surgery. And this is how the CT looked. So what is your finding? There's an interesting finding in this patient. So what we're seeing here is this inversion of the uterus. It's an inverted uterus that carries residual tumor within. So inverted uterus is the interesting finding on this CT scan. It almost looks like a polypoidal growth that is filling the vagina, but a closer look tells you that this is an inverted uterus. Okay, now going on to what is the definition of a pedunculated submucosal fibroid? Pedunculated fibroids are those fibroids where the attachment is less than 1/3 the size of its maximum diameter. So that's the definition of a pedunculated fibroid. Why is this important? A pedunculated fibroid should not undergo a uterine artery embolization because it will just get cut off from the point of its attachment and can bleed profusely during the when it gets necrosed off. And also it will become a nidus of infection when a pedunculated subserosal fibroid is embolized, because it will just fall off into the peritoneal cavity and become a nidus for infection. So that's the definition for pedunculated submucosal fibroid. All protruding polypoidal growths are not benign. This is a protruding polypoidal endometrial carcinoma. I want you to again drag your attention to the signal intensity of this lesion. It is intermediate in signal intensity. This kind of intermediate signal intensity, wherever it is in the body on MRI, it is always a sinister sign. And when we look at the diffusion weighted imaging of this patient, we see that there is restricted diffusion, and ultrasound really shows a polypoidal echogenic growth, but you can't characterize this very certainly on an ultrasound. Now, summarizing, what are the contraindications for uterine artery embolization for fibroid treatment? So, no uterine artery embolization for pedunculated subserosal fibroid, for a submucosal fibroid, for a degenerated fibroid like this. This again is a benign leiomyoma, because we know despite the degeneration, there are lakes of these hypointense tissue, which is similar to the muscle. And so this is a benign leiomyoma. Again, this kind of degenerated fibroid is a no for uterine artery embolization, and a cervical fibroid is a no for uterine artery embolization. Again, before working up a patient for uterine artery embolization, one should also exclude atypical fibroid and malignant uterine masses. And that is again one of the rules for MRI while evaluating a patient with fibroid. So with this, we've come to an end of the first session on the fibroid matters. What we saw in this session is the difference between a typical versus an atypical fibroid. I showed you the entire gamut of degenerated fibroid in this session. And we also discussed contraindication to uterine artery embolization. So now let's move on to matters of adenomyosis. I've shown you example of an adenomyosis, which is mass-like along the anterior wall of the myometrium. And this is on the sagittal, on the coronal and axial image. We see this hypointense mass on T2 weighted image with these microcysts. And on T1 weighted image, there are some bright focus. In adenomyosis, what is the pathophysiology of adenomyosis? Pathophysiology of adenomyosis is ectopic endometrial tissue which goes into the myometrium and thickens the junctional zone. A normal junctional zone is dark compared to the outer myometrium. That is because of this very tightly packed smooth muscle cells in the junctional zone that gives it the dark appearance. And the outer myometrium is loosely packed smooth muscles, and so it has this hyperintense appearance. When there is adenomyosis, the junctional zone will thicken. Normal junctional zone thickness is about 5 to 8 millimeters, but when there is diffuse adenomyosis, there is thickening of this junctional zone by greater than 12 millimeters. So much is the thickness of the junctional zone in this example with diffuse adenomyosis. When there is increase in the thickness of greater than 12 millimeters, MRI has got a sensitivity specificity of 85-96 for the diagnosis of adenomyosis. Focal adenomyosis is when this adenomyosis happens to one side of the myometrium, and the classic appearance of adenomyosis are these microcysts, which is due to lakes of ectopic endometrial tissue along with cystic glandular hyperplasia, and that is the pathophysiology behind this microcyst appearing within the focal adenomyoma. This T1 hyperintense foci, though a classic finding, is seen only in half the patients, and this T1 hyperintensity is because of cyclical bleed within these endometriotic lakes. But this diagnosis of adenomyosis is not without pitfalls. Some of the pitfalls that we need to remember is the transient myometrial contraction. There can be apparent thickening of the junctional zone during the cycles because of contraction of the uterus to expel the menstrual blood. There could be also loss of zonal anatomy in a patient who's undergone radiotherapy and in a post-menopausal woman, confusing and looking as if there is a thickened junctional zone. Also, sometimes a leiomyoma can mimic focal adenomyoma. And last of all, invasive solid endometriosis can be a close mimic of focal adenomyosis. And let me show you an example. So this is a 31-year-old female patient with a deep infiltrating endometriosis. What you can see here is this thick endometriotic plaque, a retrouterine location, causing a mild retroversion of the uterus and bowing of the endometrial cavity to the opposite side. In the coronal image, again, you can see this thick deep infiltrating endometriotic plaque. In a closer look, you can actually see all these microcysts because of the same pathophysiology as the adenomyosis, but the junctional zone is seen separate from this mass. Okay, so that is the giveaway for the diagnosis. Junctional zone is here, but this endometriotic plaque sits in the retrouterine location and infiltrates the outer myometrium. So that is deep infiltrating endometriosis in the retrouterine location, typically completely obliterating the pouch of Douglas. In this patient, you can also notice that there is a large endometrioma, which is multilocular endometrioma with dark contents because of blood products. Closer look at T1 weighted image again shows multiple T1 hyperintense focus within this endometriotic plaque, again because of repeated hemorrhage within this ectopic endometriotic tissue. So this deep infiltrating endometriosis can be a close mimic to focal adenomyosis, and the important way to differentiate the two is to identify the normal junctional zone. So with that, let's move on to this variant of adenomyosis. What is the diagnosis here? We see a typical thickened junctional zone, which is focal, and a closer look at this lesion shows a cystic change within. So the cystic change is because of repeated hemorrhage and cavity formation. And when this cystic mass is contiguous with the junctional zone, we can confidently make a diagnosis of cystic adenomyosis, and that is what this patient had. So the key to diagnosis is its contiguity to junctional zone. What is the diagnosis in this patient? We are seeing again a cystic mass, which is very dark, but it's separate from the junctional zone. And we're at a closer look at this lesion, we see that this lesion is near the corner of the left corner of the uterus, and it's got this hypoechoic myometrium uterine wall-like appearance. So is this a rudimentary horn? No. Rudimentary horn will get attached more inferiorly near the cervical isthmus, but this mass is near the corner of the uterus. So that is the giveaway for the diagnosis, and it's separate from the junctional zone. So what is the diagnosis in this patient? It is accessory cavitated uterine mass, which is a rare Mullerian duct anomaly. These patients are usually very young and they have severe congestive dysmenorrhea. One of my colleagues, Dr. Tarni, has written a very good paper about this condition, and it's published in the recent IGRI article, and you guys can read more about this condition in that article. And typically, these patients have normal uterus, tubes, and the ovaries. They can be separately identified from this mass lesion. What are the other close mimics and close differentials for cystic uterine masses? Other differentials include this rudimentary horn. And in a rudimentary horn, the normal unicorn weight uterus will be deviated to one side. And the rudimentary horn, look at this typical location. It is near the cervix, and you have this mass which is filled with hematometra, and you can have ipsilateral hematosalpinx. So that tells you that this patient has a rudimentary horn. Another Mullerian duct anomaly, a very rare one, is this Robert's uterus, which is also a close mimic of the cystic uterine mass, where there is an almost complete septate uterus, but that septa just goes and attaches to one side of the uterine wall. And so that part becomes a non-communicating cavity which collects blood, and there's an ipsilateral hematosalpinx. So ipsilateral hematosalpinx and the septa-like septa, which is continuous and attaches to the ipsilateral wall, is the giveaway for a Robert's uterus. So that is again a close mimic for a cystic uterine mass. And we already saw cystic adenomyoma, and we already saw cystic degeneration of fibroid. So these are the causes for cystic uterine masses. So to summarize, we saw ACM, where it is separate from the junctional zone. Rudimentary horn, we can see the normal uterus deviated to the opposite side. We saw Robert's uterus with a complete septum and ipsilateral hematometra. And we also saw a cystic adenomyoma, which is contiguous with the junctional zone. So the take home is to know the difference between focal and diffuse adenomyosis. We discussed the pathophysiology behind adenomyosis. We saw its imaging features. We discussed junctional zone normal and abnormal thickness, and we saw cystic uterine conditions. So now let's move on to this scenario. This is about a 60-year-old female patient who was treated for breast cancer, and she was on tamoxifen for 5 years when the scan was done. So how will you report it is what I want you to think about. So what we're seeing here is obviously a greatly thickened endometrium, and I want you to think about how will you frame the report for this ultrasound. When you're thinking, let me take you through endometrial thickness and the cutoff. Okay. So in a postmenopausal woman, the endometrial cutoff is based on whether they are symptomatic or asymptomatic. So if the postmenopausal woman, where the definition for postmenopausal woman is a patient who is amenorrhea, who had not had a menstrual period for 1 year. Okay. If this patient has bleeding, then if a postmenopausal person has a bleeding, then the cutoff is greater than 4 millimeters. If the thickness is greater than 4 millimeters, the chance of endometrial cancer is 6.7%, and thus the next thing to do would be to do an endometrial biopsy. But if it is less than or equal to 4 millimeters, the chance of endometrial cancer is less, so do nothing. When a postmenopausal patient on an incidental ultrasound, which is done as a part of a routine checkup, has no vaginal symptoms, no bleeding symptoms, you do an ultrasound and you think that there's endometrial thickening, what should you do? Then you look at the thickness of the endometrium and see if it is greater than 11 millimeters or less than 11 millimeters. If it is greater than 11, the chance of cancer is about 7%, and so you would biopsy. And you will also assess risk factors for endometrial cancer before deciding on biopsy. So meaning a postmenopausal woman without bleeding, when we find endometrial thickening that is greater than 11 millimeter, should get investigated with an endometrial biopsy only if there are risk factors like obesity, hypertension, diabetes, something that predisposes her to endometrial cancer. If it is less than 11 millimeter, the chance of cancer is very, very small, that is 0.002%, so do nothing. Tamoxifen, a patient on tamoxifen with abnormal uterine bleeding has 2 to 3 times more chance of endometrial cancer compared to the general population, especially when the patient has had tamoxifen for 5 years. And this risk doubles if the patient has had it for 10 years. So the cutoff is very similar to a patient who is postmenopausal with bleeding, and the cutoff is 5 millimeters. So if it is greater than 5 millimeters, you must refer this patient for endometrial biopsy definitely, because it is important to differentiate whether the patient has got cystic hyperplasia, polyp, endometrial cancer, or uterine sarcoma, because the chance for both sarcoma and endometrial cancer is 2 to 3 times higher than the general population. So how would you frame the report for this patient that we just showed? You must definitely refer this patient for endometrial biopsy and evaluation, because the thickness is definitely more than 5 millimeters. These are examples to show you that it is this is a submucosal fibroid on ultrasound. which is well-defined and more hypoechoic, compared to an endometrial polyp, which is little more hyperechoic. And this is a cystic hyperplasia in another patient on tamoxifen and endometrial cancer. As you can see, it is very difficult to differentiate one from the other very categorically. So when in doubt, you must always refer the patient for endometrial biopsy, and the risk stratification should be done based on whether the patient is symptomatic, asymptomatic by the referrer. This is an example of an endometrial polyp, which is echogenic, and you can see it attached to the fundus. And on post-contrast image, it is intensely enhancing. So we should definitely, the answer for this scenario is that in a 60-year-old breast cancer on tamoxifen for 5 years, when you see something like this, it's more than 5 millimeters in thickness. So don't try to characterize this endometrial thickening as cystic hyperplasia or polyp or a cancer. You refer this for endometrial biopsy. So the magic number, take home about the endometrial thickness, the magic number is 4 to 5. Do not manage endometrial thickening alone in a postmenopausal woman. You have to take into consideration the symptoms and the risk factor. For tamoxifen, the size cutoff is different, and you must evaluate this patient earlier than the normal. You will have low threshold for endometrial biopsy in a patient who is on tamoxifen. Let's move on to matters of the cervix now. So I've shown you a typical carcinoma cervix where there is intermediate signal intensity, infiltrating growth in the cervix, and another growth in the first image, which is more exophytic in nature. So you can have two varieties, which either an exophytic tumor or an infiltrating cancer. There can be parametral infiltration like as shown in this image, where part of the cervix uninvolved cervical stroma is very dark, but when it gets infiltrated and replaced by tumor, that in itself is a sign of parametral infiltration. In this patient, you again, in addition to infiltration and replacement of the cervical stroma, you have these fat stranding and spicules going into the parametrium. So that's a definite sign of parametral infiltration. While all these classic appearances are very fine, not infrequently you can have a diagnosis which is only cervicitis despite a lesion that looks just like cancer. So this patient had a woody, hard cervix on clinical examination. The clinician was very sure that this patient has a malignancy. We did MRI to stage the malignancy. Repeated biopsies 3 times in this patient yielded only cervicitis. And unfortunately, I don't have a follow-up imaging to show, but the clinical notes say that this patient at 1 year follow-up did not have any residual thickening that was felt per vagina. So cervicitis can be a very close mimic of malignancy, and this is something to keep in mind. I've shown you here 3 different patients with 3 different kind of pathologies. I want you to think, what are these lesions? Let's look at each of them one by one. So the first one is a tunnel cluster. Basically, cystic dilatation of the endocervical gland is what gives you this conglomerate cystic lesions which are lined along the endocervical canal, and this is a typical tunnel cluster. And you can see this diffusion weighted imaging showing facilitated diffusion. And this is an example of an adenocarcinoma of cervix, which again looks like a cluster of cysts, like in the previous example. But the difference is that these cysts are all uniform in size. So when you see these cystic lesions in the cervix, which are nearly uniform in size, that is an alarm sign, and you must biopsy this lesion. Okay, so that is the take home from this slide. This is an adenocarcinoma of the cervix. Let me show you adenoma malignum, which is basically a mucin-producing adenocarcinoma of the cervix. It's a well-differentiated mucin-producing adenocarcinoma of the cervix. And these patients, again, you can notice that there is very uniform sized hyperintense lesions, and the endocervical canal is replaced by a similar kind of a lesion. So this, you should not mistake this you should not mistake this kind of appearance for a tunnel cyst. You must evaluate this and biopsy this and exclude malignancy. So when adenocarcinoma has this appearance, which is very much like what we see in the rectum and the colon, markedly hyperintense, this is a gastric type adenocarcinoma of the cervix. It's important to recognize this variety and tell your clinician categorically, because these do not respond very well to chemoradiotherapy. Okay, so these patients, even if they have parametrial infiltration sometimes, we might have to give chemotherapy. Radiotherapy definitely does not work. Chemotherapy for a while to downsize, and these patients might have to go for pelvic accentration to achieve cure for this kind of masses. So that is the importance of identifying the signal intensity and alerting your clinical colleague of a potential adenocarcinoma of the cervix with this kind of signal intensity. Rarely we can have other unusual histology, which is a neuroendocrine tumor, which is of small cell type. These tumors, again, notice the signal intensity. It is more hyperintense. In this particular patient, it was exophytic, but these could be infiltrating as well. You can't make an imaging diagnosis of this particular entity, but you should suspect an unusual histopathology with this kind of signal intensity and alert the pathologist to do more immunohistochemical markers to make the appropriate diagnosis in these patients. How about this? Compared to the infiltrating cancer I showed you initially, can you make out that this is extremely homogeneous? So just like anywhere in the body, homogeneous mass, one needs to consider lymphoma as a diagnosis. The large size, the way it is infiltrating the entire organ, and it is homogeneous in nature, is the giveaway for this diagnosis of lymphoma of the cervix. And this patient also had this perinephric soft tissue and turned out to be a chronic lymphoid leukemia, and there was a growth in the cervix. This is another patient with lymphoma with chronic lymphoid leukemia, and this patient had a soft tissue in the cervix and a perinephric soft tissue and hydronephrosis. Okay, sometimes history is very, very important to make the correct diagnosis. Just because there's this infiltrating soft tissue in the cervix, it does not make it malignant. This patient had this kind of irregular intermediate signal intensity lesion, which is going right to the anterior wall outside the uterus because of placenta increta. So history is very important when you're trying to interpret images. So what did we see so far? We saw carcinoma cervix, we saw some of its mimics, we saw some unusual cervical neoplasms, and we also saw Nabothian cysts, which are small and large in a tunnel cluster. Let's now go on to the vulva, vagina, and the urethra. I want you to think, what are these lesions? I've shown you 3 different images of fluid signal intensity cystic lesions. I want you to think what these are. Let's look at them one by one. So the first one is a giant Bartholin cyst. In fact, this was an abscess. This T1 hyperintense signal of its contents, and the diffusion restriction was because of the thick proteinaceous abscess material within the lesion. So as you can notice, this is a large elongated labial lesion, or usually Bartholin cyst will be in the inferior third of the vagina. So when you have inferior third vaginal lesion extending into the labia, you need to think of a Bartholin cyst. As opposed to that, in a giant Bartholin cyst like this, you might only have to give differential diagnosis, which include epidermoid cyst, a giant Bartholin cyst, or a mucus retention cyst. So the differentials for this would be long, and you really cannot differentiate one from the other when the lesion is so huge. We already saw tunnel cluster, which has cysts in the cervix. From there, one of these cysts can really grow and become a giant Nabothian cyst. And this is very uncommon lesion where one of the cysts had become very large, and this cyst had a signal intensity again on T1, which was very bright. And in this patient, this particular signal intensity was because of very mucoid content within the cyst because of chronic retention of its contents. As opposed to Bartholin's cyst, the Gartner's duct cyst, which is what the second example was, it is usually in the anterolateral vaginal wall. And you know this is a Gartner's duct cyst because these cysts will be above the level of symphysis pubis. So below the level of symphysis pubis will be a Bartholin's, above the level of symphysis would be a Gartner's duct cyst, and Gartner's would be in the anterolateral vaginal wall. As opposed to those examples, the third example I showed you is a cyst that is surrounding the urethra. So this cyst is a urethral diverticulum in a female patient, which is usually located in the mid and distal urethra. And when it is totally circular and it is surrounding the urethra, it is called a saddleback diverticulum, and that is what this patient had. As opposed to a urethral diverticulum, how will you differentiate it from a Skene's gland cyst? A Skene's gland cyst will be along the anterior aspect of the external urethral meatus. So when you have a cyst near the meatus of the urethra, that will be a Skene's gland cyst. From the cyst, so we've seen the examples of cystic lesion. Let's move on to some unusual vulval lesions. Vulva is also a location for multiple types of mesenchymal tumors, and this was a liposarcoma of the vulva. The most common malignant tumor of the vulva is the squamous cell carcinoma of the vulva, but you can have unusual mesenchymal tumors in this location. And this is a liposarcoma, which is bright on T2 weighted image without fat suppression, but fat suppressed images show drop in signal. So this was a liposarcoma. Let's move on to this very interesting case that we saw. 17-year-old female patient who had a progressively increasing vulval swelling over the last few years is the history. So when you look at this patient's MRI, we saw this very diffuse lobulated submucosal location masses which are present in the vulva and also along the entire urethra. The entire urethra has a similar submucosal hypointense mass. Closer look at the rectum also shows that the muscularis layer of the anal sphincter complex and the lower rectum has this hypointense appearance. Okay, and you can see that also in the axial image where the rectal wall and the entire vulva has this hypointense masses. Then we went on to take a closer look at her upper abdomen on the MRI, and we noticed an unusual swelling. So we called back the patient for CT and noticed that the entire esophageal wall was diffusely thickened in this fashion. And there was some lobulated eccentric compressions on a barium swallow, which was done in the past. So the diagnosis in this patient is diffuse leiomyomatosis, and this patient is being worked up for an X-linked Alport syndrome. We've still not got the result, but that is what we're thinking of in this patient, a diffuse leiomyomatosis involving all the smooth muscles of the body. The smooth muscles of the esophagus, vulval region, anal sphincter complex, all those areas show similar diffuse leiomyomatosis. So what did we see? We saw different cystic lesions in the vulva, vagina, and the urethra. We saw an example of vulval liposarcoma, and we also discussed the most common tumor in the vulva, that which is squamous cell carcinoma. We saw an example of diffuse leiomyomatosis. Let's move on to ovaries. So I've shown you examples of Kuchenberg's tumor, 2 examples. Where is the primary is the question I want you to think about. Krukenberg's tumors are most commonly bilateral. They're most commonly solid. 80% of them are bilateral, 80% of them are solid. But almost always, certain primaries give rise to solid Krukenberg's tumor. The top on the list is breast, stomach, lymphoma, and the uterus. So this is what should be in our checklist when we see bilateral solid Krukenberg's tumor. Krukenberg's tumor, unlike the primary ovarian malignancies, are solid. They are smoothly lobulated, bosselated tumors, most commonly bilateral. But small percentage can be unilateral, 20% can be unilateral, 20% can be cystic. When we see bilateral cystic masses like this, you need to think of a different set of primaries. Colorectal, appendix, and biliary origin masses tops the list when you see bilateral cystic ovarian masses. Let's move on to tubo-ovarian abscess. When you see this intensely enhancing uniform wall in any lesion in CT scan, you must think of inflammatory condition. And so is true in a tubo-ovarian mass. When a tubo-ovarian mass has this intensely enhancing wall, this is because of inflammation associated hyperemia, and so there is more contrast enhancement, and usually this is uniform in thickness. So this is a tubo-ovarian abscess. Let's move on to another example of a 28-year-old female patient who had presented with acute abdomen, and the history was she presented with acute abdomen after having a HSG for infertility workup. So what do we see here? Infected endometrioma, which is again a tubo-ovarian abscess. Again, notice the intense enhancing uniform wall, and this mass here has a retort shape. Okay, in fact, this is an inverted retort, and you have a retort shaped mass and another cogwheel shaped mass, and you get this kind of appearance because of thickened endosalpinges that are seen within the fallopian tube. So now let's move on to this very interesting patient who was a 10-year-old girl, and she presented with lower abdominal pain for 2 weeks duration. And also another relevant history was that she attained an early menarche at 9 years of age. So what you see here are bilateral multilocular cystic lesions in the ovaries. And while evaluating her, we saw that her TSH was really high, 583, and ultrasound thyroid showed evidence of diffuse thyroid disease. The liver looked literally like a cirrhotic, thyroid looked like a cirrhotic liver, and there was evidence of an autoimmune thyroiditis in her. So putting these together, the patient was given thyroid supplements and called back after 3 months for reassessment. All the multilocular cysts that we saw in the ovaries had disappeared, and the volume of the ovaries had returned to normal. So what is the diagnosis in this patient? This is a patient with Van Wyck-Grumbach syndrome. So what is that? Van Wyck-Grumbach syndrome is a condition where there are bilateral ovarian cysts in a patient who is hypothyroid, most commonly due to autoimmune thyroiditis. Because the TSH is so high, it will stimulate the FSH receptors, and there will be increased estrogen production. And so ovaries will become polycystic, and there'll be development of secondary sexual characteristics. So this particular condition should not be mistaken as an ovarian neoplasm, and no surgery should be done. So the take-home message from this case is when you have young girl with the early menarche, bilateral ovarian lesions like this, you must evaluate the thyroid and exclude other causes for precocious puberty in this patient. So bilateral multicystic ovaries, chronic autoimmune thyroiditis, and pseudo-precocious puberty, think of Van Wyck-Grumbach syndrome. So in this particular slide, I want you to think, where is the hydrosalpinx? Is it a hydrosalpinx or is it a mass, is the question. So this is a patient who had both. So this component with an incomplete septa is the hydrosalpinx, and this mass, which is multilocular with septa running from wall to wall is a mass, is a neoplasm, and this was an ovarian mucinous cystic neoplasm and a hydrosalpinx. And this is the same example that I showed you earlier with the urethral diverticulum. So this patient had three things. What are the other thin-walled multilocular masses? Ovarian hyperstimulation is another example of bilateral multilocular masses, which we already saw. Other example is a theca lutein cyst, especially you need to think of one in a gestational trophoblastic neoplasm. You can also have mucinous adenoma as in this example. But in our country, you should also include this as the differential diagnosis for a multilocular cystic lesion. As in this patient, there's a multilocular cyst in the pelvis. There are 2 more lesions in the left side of the peritoneal cavity, and there are multiple in the upper abdomen. So the diagnosis is hydatidosis. So add this to your differential diagnosis. This is a classic endometriosis with the shading sign. What is shading sign? The signal intensity of the cystic mass on T2 weighted image is less dull compared to the signal on T1 weighted image. So that is a shading sign. This is because of blood products within this mass giving away a class. This is a classic appearance of endometriosis or an endometriotic cyst. Another example of a 38-year-old female patient with a lower abdominal pain radiating to the left flank for 2 months. Again, a classic shading sign of endometriosis. T1 bright lesion and becomes duller, gets shaded on T2 weighted image. That is a T2 shading sign of endometriosis. When do you suspect malignant transformation in endometriosis? Obviously, when you see a solid component. But what is an earlier sign? So the earlier sign is when there is loss of T2 shading. That is a sinister sign, and you need to evaluate that patient. There could be 2 reasons for loss of T2 shading. One could be malignant transformation. The second could be infection in an endometriosis. So these 2 things must be thought about when you see loss of T2 shading in a known endometriotic cyst. This is another example showing you a solid component and loss of T2 shading. T1 bright lesion, this is almost similar and looks fluid signal intensity rather than a T2 shaded appearance. In a classic endometriomas, you need to think of malignant transformation. So this is an example where there was an ovarian tumor, a malignant ovarian mass, and endometrial thickening. So I want you to say which of these is the diagnosis. Is it endometrioid carcinoma ovary, clear cell carcinoma ovary? Is it a granulosa cell tumor, fibrothecoma, or a thecoma in a 27-year-old patient with a known endometriosis? Obviously, what are you seeing in this patient? You're seeing a URADS 5 ovarian mass, irregular papillary growth, and you're seeing endometrial thickening. So you need to think of an endometrioid carcinoma of the ovary and a concurrent endometrial carcinoma. In an endometrioma, when it turns malignant, most common cancer will be an endometrioid carcinoma. The other cancer that can occur is a clear cell carcinoma. And you can have endometrial thickening in an endometrioid carcinoma in up to 30%, and it could be because of various reasons. It could be polyp, hyperplasia, or a cancer, but all of them have to be biopsied and cancer has to be excluded in these patients. Now, in this scenario, I want you to think whether this is benign or malignant. I've just shown you these to emphasize on a concept. This is an arterial phase image, a venous phase image, and a delayed phase image. What you see here is slow, progressive enhancement. When you see this kind of pattern anywhere in the body, most likely it will be benign. And this is an example of a CT example of a fibroma, which was a slowly and progressively enhancing mass on a CT scan. You can see there's an arterial phase, a venous, and a delayed phase where the ureter are opacified with contrast. With this, let's move on to some of the T2 hypointense masses. So I've shown you images of 3 patients here. For all the 3 are young women with ovarian masses. They have a solid cystic appearance and they have a T2 hypointense solid focus. So I want you to tell me whether these are benign, malignant, or are they indeterminate? Can we offer a specific diagnosis is what I want you to think about. The first, with an eccentric T2 hypointense solid component and a cystic lesion adjacent to ovary with a thickened stroma, is a Brenner's tumor with a serous adenoma. And this is a definitely benign lesion because you see a T2 hypointense solid component, which is completely not showing restricted diffusion. There is a diffusion blackout phenomena, meaning to say it is black on both diffusion and ABC. And so this solid component is very highly suggestive of a benign component of the lesion. So this particular tumor, Brenner's with serous adenoma, is a very rare combination, but Brenner's tumor, which is a stromal tumor, can be associated with other neoplasms. Most common would be the mucinous cystadenoma and a teratoma, but this was associated with a serous cystadenoma. So a 22-year-old patient with a cystic mass and an eccentric T2 markedly hypointense solid component with a papillary excrescences. So is this benign or malignant? Again, this was a benign lesion and a serous cystadenoma was the diagnosis in this. Serous cystadenofibroma was the diagnosis in this patient. Again, the concept here is when you have a solid cystic mass and the T2 hypointense component, when it's so dark, you need to think of benign etiology. That's the concept to drive across. You don't have to reach a specific diagnosis. You need to say that these features are suggestive of benign stromal neoplasm of the ovary. The third example is that of a 15-year-old girl with this more heterogeneous appearing T2 hypointense, but there are some cystic changes as well. Closer look showed that there was endometrial thickening, and on ultrasound, this mass was isoechoic and there was a color score of 2. So when you have a color score of 2, this becomes a URATS 4 lesion, and that is why this patient had an MRI. And on the MRI, we again said this is a benign stromal tumor because it was T2 hypointense. Nevertheless, it was heterogeneous, and the diagnosis of this patient was a fibrothecoma. We said it's a benign stromal tumor because there's also associated endometrial thickening, and we know that fibrothecomas are associated with fibrothecomas or thecomas associated with endometrial thickening. So now these are examples of 3 different patients with masses in the pelvis, and I want you to tell me whether these are uterine masses or ovarian masses. And all the 3 of them presented with a similar clinical picture. They all have abnormal uterine bleeding. So can you differentiate one from the other is the task ahead of us. So let's take a look. The first patient, 48-year-old, when we look at the point of maximum contact between the uterus and the mass, which is really well-defined, very dark on T2 weighted image, and with no bridging vessel sign, this is classical of a fibroma. Okay, fibroma of the ovary. And when you look at the ultrasound, you see a mass which is well defined and there is shadowing, posterior acoustic shadowing. This ultrasound picture itself is very classic of fibroma. Okay, and let's move on to the second example. This is more heterogeneous. Again, when we look at the point of maximum contact between the uterus and the mass, you don't see a bridging vessel sign. And this again on ultrasound, unlike the fibroid, which is supposed to show a Venetian blind appearance, alternating bands of shadowing and echogenic line, this shows more shadowing. So this is again a benign sex cord stromal tumor and turned out to be a fibrothecoma. The third example, there is indeed a bridging vessel sign. So these are subserosal fibroid, and ultrasound of this patient showed this classic Venetian blind appearance of a fibroid. So thus on MRI, you can differentiate whether the mass is of uterine origin and ovarian origin using the bridging vessel sign and the signal intensity of the mass. So we've seen several examples of T2 hypointense masses, which could be either ovarian or uterine origin. The ovarian origin masses with T2 hypointense signal would include endometrioma, hemorrhagic cyst. Also in this list, you should include torsion ovary. When the composition is made of fibrous tissue, you need to think of fibroma, fibrothecoma, thecoma, or a cystadenofibroma. A mixed cellular lesion could be a Brenner's or a stroma ovariae. If it is of uterine origin, the T2 dark masses, these should be the differential you need to think of. You need to think whether it's adenomyosis, whether it's Mullerian duct anomaly, hematometra, and I've shown you other examples, and leiomyoma. So it's not darker than muscle, it's a mistake here. It has to be either equal to the muscle is what I would say. Okay, not darker than the muscle, skeletal muscle, similar to skeletal muscle. This is an example of a 29-year-old female who was a pregnant woman who presented with low backache. And what we see here is an enlarged ovary, very T2 hypointense ovary with peripheral follicles. And this is a classic torsion of the ovary. And on ultrasound, this was indeed a avascular mass, a classic picture of a torsion ovary. In this example, I've shown you a 23-year-old who was treated for a hydatiform mole. And what this patient has is a T2 markedly hypointense mass in the, it is paracervical in location. And a closer look shows you multiple similar masses along the left lateral wall of the pelvis. So what is the diagnosis in this patient? The history is classical, 23 and had history of treated hydatiform mole. So this is actually avascular AV malformation in a patient who was treated for gestational trophoblastic neoplasm. And angio shows you this classical tuft of vessels, and contrast enhanced MRI shows this intensely enhancing tortuous dilated vessels in the left side of the pelvis. So not all T2 hypointense lesions in the pelvis are neoplasms. You also need to consider signal voids from vessels. Most of these AVMs from a gestational trophoblastic neoplasm will resolve spontaneously, but 10 to 15% will persist, and only 2% of them will have refractory vaginal bleeding, and those are the ones which will need treatment. And this is one of those patients who had large AVMs and needed angioembolization to treat her. Let's now move on to the matters of the dermoid. This is a classic CT appearance of a dermoid with a cystic component, fat component, soft tissue component. But most of the time, dermoids, when it's found on CT, it is because this patient presented acutely with a suspected acute abdomen from torsion, and the dermoid would have acted as a nidus, or the dermoid was just incidentally picked up on CT scan done for some other purpose. Most of these would usually get diagnosed on ultrasound examination. And if the ultrasound is not able to characterize, MRI would be the modality of choice. So I've shown you a variant of a dermoid, which is very rare, stroma ovariae, where there is thyroid tissue within the dermoid, giving this intensely enhancing soft tissue component. And there is also calcification. So this diagnosis, it's very hard to make on CT, and this turned out to be a stroma ovariae. This is an example of a classic torsion with the dermoid with the torsion, and you can see a whirlpool of vessels on the side of the lesion of the mass. And you can see all the components of a dermoid, the fat, calcification, and the soft tissue component. How about this? This is a patient who presented acutely with peritonitis. A closer look shows you fat fluid levels. And these fat fluid levels was because of a ruptured dermoid, and a chemical peritonitis was the reason for her symptoms. How do you differentiate a mature from an immature dermoid? An immature dermoid will have more soft tissue components, more calcifications, and the fat itself will be a small component of the mass. So when you see a multilocular mass with a lot of soft tissue, enhancing soft tissue components, and small amount of fat, which is scattered like this, you need to think of an immature dermoid. Let me take you through an interesting patient who was a 33-year-old with a history of ovarian cystectomy for dermoid. And this patient, on follow-up, had normal tumor markers, but CT showed all these large masses, which was indolent and slowly growing. Biopsy of this showed mature dermoid elements when she was actually treated previously for an immature dermoid. So what is this condition? This is the growing teratoma syndrome. Growing teratoma syndrome, when you biopsy these masses that are growing in the peritoneal cavity, though the primary was an immature teratoma, biopsy of these will show you mature components only, because these mature components of teratoma will evade the chemotherapy and the radiotherapy given to the patient and will slowly and indolently grow with time. And that is the growing teratoma sign. And that is the very reason why the tumor markers in these patients will be normal. So this is growing teratoma sign. So what are the take-home messages from this session on ovary? Krukenberg's morphology can point towards the primary. You need to have a specific review areas for each morphological type of Krukenberg's tumor. I showed you how to differentiate between pyosalpinx, hematosalpinx. We also saw a lot of examples of T2 dark masses, and we also saw matters of dermoid. We'll finish with this last session touching on the other pelvic masses. This is an example of just every now and then in a gynae oncology MDT, you'll come across this large abdominopelvic mass, which will be referred as an ovarian mass, but a closer look at the vessels supplying the tumor will tell you that this may not be an ovarian origin mass. So in these patients, it's a high index of suspicion, and prompting the clinical colleagues to refer this patient for biopsy is what will get you the diagnosis. So this was a gist. This is another classic pelvic mass where you can make a pathological diagnosis. When you have this lamellated appearance in a pelvic mass, this is an aggressive angiomyxoma. If you did a contrast enhanced image, you will see slow progressive enhancement in an aggressive angiomyxoma. This is an example of a fibromatosis in a patient who was treated for cancer previously. And this patient in March 2018 came back with this large retroperitoneal mass. So you shouldn't pull the gun in a well-defined mass that does not look like a usual lymph node and call it recurrence. You must prove the diagnosis with a biopsy, and this turned out to be a fibromatosis. So we did nothing for this patient, and with time, you can see progressive decrease in size. So that is a classic temporal progression of fibromatosis, which can occur following a cancer treatment. This is an example of a fat soft tissue fat and soft tissue density mass in the pelvis, and this is extramedullary hematopoiesis. This is a classic example of a unilocular cyst, and a close look at the cyst itself shows you multiple lamellated soft tissue components which are showing restricted diffusion. These are actually keratin pearls within an epidermoid cyst, giving this beautiful MR appearance of lamellated onion ring-like appearance within the cyst. Finally, a tail gut cyst can also be a cystic lesion in the pelvis, and typical retrorectal location of the cyst, multilocular nature, is what will give you the diagnosis of a tail gut cyst. Lymphoceles can be very large, like in this example. Lymphoceles occur after pelvic lymphadenectomy performed on gynecological patients, and they can be very large, and you should not say that this is a recurrence. Multiloculated cystic lesions with numerous internal septations on ultrasound is a lymphocele, and this patient needed sclerotherapy for treatment of this very large lymphocele. Finally, I want to finish the session with this case. This patient was referred for referred as ovarian malignancy. There was this intensely enhancing mass, abdominopelvic mass, and CT venous phase showed that the epicenter of the mass was abdomen and pelvis, but the maximum component of the mass was at the aortic bifurcation. And as you go down, you see the stuffed of vessels here. Come back to that point. Tuft of vessels supplying this tumor over here. When you trace it up, you see that the gonadal vein is dilated. So confident diagnosis of ovarian mass was made and the patient was taken up for surgery. And when you look at the coronal image again, it is an enhancing mass more than usual that we see in an ovarian malignancy. Lot of vessels. And what is this large vessel that we're seeing? That is the inferior mesenteric artery supplying the lesion. Of course, we did not notice that before the patient went for surgery. And the patient on the table had a hypertensive crisis while the tumor was being handled. When we looked back at the history, there was no past history of hypertension, there was no chronic medications or palpitations, and the pathology turned out to be an extra-adrenal pheochromocytoma from an organ of Zuckerkantel. So looking back after at the scan after the histopathology was available, we saw that the ovary was in fact atrophic and was seen in the pelvis. So that was a difficult call. So not all abdominopelvic mass will be an ovarian mass. Going through the vascular supply of the mass and knowing the different compartments and what are all the possible differential diagnoses can sometimes prompt, but we nevertheless will make mistakes. So vascular supply, morphology, location, and the temporal profile can give you a clue while you're handling pelvic masses. And that is again something to consider when you're interpreting pelvic masses. So we've seen a whole lot of conditions today of different parts of the pelvis. I've given you a whole lot of differential diagnosis and tips to consider. But the main messages are these: stay tuned to the clinical presentation, optimize your imaging protocol, have a multimodality approach when you're dealing with gynecological pathologies, and develop a method to a madness. Most of what I've said today, we've written it in our different publications earlier, but this is one of the review articles that you can look at to, again, review many of what I've said today. And thank you very much. And these are some of the recommended reads. The most recent and the current favorite is this last one, and that is something that is worth the read. And thank you very much.
Thank you, Dr. Anu, for the excellent collection of cases. I have got a lot of questions for you. To start with, what is stump lesion?
Stump lesion is basically a stromal tumor of undetermined malignant potential. Basically, the pathologist and the academic community does not know what is the malignant potential of the lesion. They've seen a spectrum of behavior of that lesion. They do not know whether that particular lesion will behave like benign lesion or will it behave like malignancy. It could do both. So that is a stump lesion. When pathologist does not know where to put it, they put it under stump.
What is a cellular fibroid?
Cellular fibroid is basically a fibroid which is very cellular. So a hypercellular fibroid can have intermediate signal, and it is a rapidly growing fibroid, and that is why it is cellular. So these fibroids will mimic and will have an atypical appearance, and that is a cellular fibroid.
When should we suspect leiomyosarcoma on imaging?
When you see a large solitary lesion, when you see atypical features of fibroid, that's an alarm sign. There is no wrong in calling it atypical fibroid. So basically, when you say atypical fibroid, you're telling the gynecologist that it is better to ask the gynae oncologist to handle the case. That is the message you're giving them when you write atypical fibroid. You don't have to commit to a diagnosis of leiomyosarcoma in your radiology report. What we are expected to say is typical or atypical.
Yeah. There are two questions on endometrial stromal sarcoma. How to differentiate stromal sarcoma from CA endometrium, and would diffusion help between the mucoid degeneration and endometrial stromal sarcoma?
Okay, I'll take the second question first. Your diffusion weighted imaging will not help in differentiating the two entities. Both will show facilitated diffusion, and your contrast enhanced MRI will help because your endometrial stromal sarcoma will have a bit post contrast enhancement, but your mucoid degeneration is going to show a slow progressive enhancement. So, but it is a tricky thing in my experience to commit to a diagnosis one way or the other, and it has to be with a biopsy. You have to get a final diagnosis with a biopsy. About the first thing, endometrial carcinoma versus endometrial stromal sarcoma. Endometrial, when a mass infiltrates the entire uterus, then and it's a very rapidly growing mass, especially in a postmenopausal woman, you will lean more towards an endometrial stromal sarcoma or a uterine sarcoma, but it is a difficult diagnosis. You will not be able to differentiate these two very categorically every single time.
Okay. Will junction zone thickening is enough to call adenomyosis, or should we have hyperintense areas within? And why microcysts appear T1 hyperintense in adenomyosis?
Okay, microcysts. The first question, junctional zone thickening alone, when it is greater than 12 millimeters, yes, that is, I've told you the sensitivity specificity 85-96. That is how the probability of you being correct when the junctional zone is greater than 12 millimeters. But when you have microcysts, it means T2 hyperintense, multiple bright areas within the lesion. That is a very sensitive sign for adenomyosis. Almost all of them will have it, but T1 hyperintensity, only 50% will have it, because not every adenomyoma will have a hemorrhagic focus within. So, but the T2 microcysts are going to be there in almost every patient.
Okay. What is the upper boundary of pouch of Douglas?
Upper boundary of pouch of Douglas is the bladder dome, and then the dome fundus of the uterus, and then it dips into the space between the uterus and the rectum, and then goes up along the anterior wall of the rectum.
Okay. How to identify normal fallopian tube when it is not dilated?
You don't have to identify. That's my answer. Okay, you many times won't be able to identify as well. So you don't have to. When it's pathological, it will be dilated. Otherwise, we don't have to bother about fallopian tube.
Yeah. What is the size cutoff for tamoxifen?
5 millimeters is the size cutoff, and when it is greater than 5 millimeters, you don't wait for symptoms or anything else. You definitely have to biopsy.
What is tunnel cluster?
Tunnel cluster is cystic dilatation of endocervical gland. So along the endocervical canal, you will have multiple cluster of cysts, and that is a tunnel cluster.
Yeah. They want you to repeat the MRI appearance of different histological types of CA cervix.
Okay, sure. The most important types I would like you to remember is not to pass away adenocarcinoma, which is early. So that is the most important take home I would like you to remember in the cervical morphology. In the this is the case I would like you to remember. When this is a tunnel cluster, if you take a closer look over here, it will look like it is all similar in size, but take the whole picture together. There are multiple sizes and shapes, but when you look at this picture, you don't have any large cysts. All of them are very similar in size, and it is it gives you that appearance that it is replacing the cervical stroma. So when you have, and there's a bit of asymmetry, it is not all around, it is to one side. So you need to think of an adenocarcinoma of the cervix in this case. And I showed you adenoma malignum, which is more florid, and the gastric type, which is just like the colonic mucinous adenocarcinoma. So chemotherapy and radiotherapy do not work. That's what I said. And a small cell carcinoma cervix, which is again a bright tumor, and a lymphoma, which is homogeneous. So these are the types.
Okay. And there are a set of questions, Dr. Anna, I'm asking every speaker. I don't know whether they are from the same PG or from different PGs. How will you differentiate endometriotic cyst from hemorrhagic cyst? And how will you differentiate AVM from RPOC? These are like standard questions I kept asking everybody. I don't know if the residents are still not clear about that.
Okay, endometriotic versus hemorrhagic, the literature is very divided. And in our work on the article that I showed you, we have dealt with that. And I would certainly refer you to read that part. One of the tips is hemorrhagic cyst will decrease in size with time because it's functional. And so a 6 weeks follow-up ultrasound to see downsizing of the cyst is a very useful sign. But if you look at a snapshot, both are going to have similar appearance. But there is a literature saying that the ADC value in an endometriotic cyst will be lower than hemorrhagic cyst. But the evidence is not strong. It's an isolated study. So that is my answer for you. So my best thing, practical thing to tell you would be do a 6 weeks follow-up ultrasound when you have a doubt whether something is hemorrhagic versus endometriotic. If it decreases in size, it's safer to play the card of hemorrhagic cyst than endometriotic cyst. If it's persistent, then you can evaluate that patient further for endometriotic cyst. If the clinical history is suggestive, you need to have a clinical history which gives you a classic history of endometriosis.
Differentiating AVM and RPOC on ultrasound.
AVM and
RPOC, written products of conception on ultrasound.
And AVM, arteriovenous malformation.
Yeah.
Oh, okay. On ultrasound, okay, retained products of conception on ultrasound, how do you make out? Okay, you'll see retain, I don't know, what exactly, I don't understand. How do you differentiate these two?
Yeah. They've asked how will we differentiate these two on ultrasound?
Just turn on the Doppler. So if you have a vascularity, which is tortuous, then you're going to lean more towards an AVM. Otherwise, you're going to think of retained products.
Vascular RPOC can mimic an AVM, and an AVM can also coexist along with RPOC. So basically, we cannot differentiate on ultrasound, but the message that we have to give the clinician is it is very vascular and we need a pre-operative embolization before they try evacuation. I hope that answers that question. And can Gartner's duct cyst also occur in the lower third of vagina?
Yeah, the probability of a cyst in the lower third of the vagina being Gartner's is less than Bartholin's. Let me put it that way. So the chance of you being right if you call something in the lower third of the vagina as Gartner's will be small. So you need to lean more towards Bartholin's.
How to differentiate a focal adenomyoma from an infiltrating deep endometriosis?
The junctional zone is the key. You have to see whether the junctional zone is contiguous with the adenomyoma or the mass that you're seeing. If it is contiguous, it's going to be focal adenomyoma. If you, like in the example that I showed you, if it's going to be separate from the junction zone, then it's going to be a infiltrating endometriosis.
There's an interesting question to you. Why is CS cervix so well marginated in many cases that you had shown?
Why is CS well marginated?
I think most of the cases that you had shown is in adenocarcinoma examples. You know?
Yeah. I mean, I'd shown you 3 examples of adenocarcinoma. I mean, 2 examples of adenocarcinoma. Maybe that's why. Yeah.
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 And another interesting question. In the last case of FIO, whether T2 would have helped to change your diagnosis, how can we save ourselves from medico-legal issues in such cases?
No, you can't. You can. Okay. First, T2 in that case, I think would not have helped, because arterial anatomy is what would have helped us by saying non-ovarian origin. And had you being biased by the clinical history is always a problem. So even if the ovary was seen, one might assume because it was so flat and atrophic, you might not think that it's the ovary. You might think that it is the suspensory ligament that is thickened and things like that. So it is a very tough call. So yeah, I think the way to save yourself from medical legal in this particular situation is to be honest with your patient. So that is the best way. And in radiology, it's always about probability of being right. So that is why we need to have a set of rules which will help us increase the chance of being right. So that is all that we can do from our side.
Yeah. How to differentiate most commonly seen bulky cervix with multiple nabothiensis from tunnel cluster versus CA cervix versus cystic apse cases shown. So I guess basically, how will you differentiate bulky cervix with nabothiensis versus mass?
Yeah, you sometimes, like in the example that I showed you, cervicitis, you can't differentiate. And yeah, so you just have to go, you can't differentiate cervicitis, which mimic the malignancy categorically, but most cervicitis won't be like that. The most commonly cervicitis will show facilitated diffusion. In that particular case, it was very unusual and it had that appearance. But most of the cervicitis will show facilitated diffusion. And if you give contrast, they will show intense enhancement because it's an inflammatory pathology. So those things can help. And about the cystic lesions, all of them are going to be bulky cervix. The morphology is what can help, as I already described, looking at the cyst morphology, whether it is uniform in size or non-uniform in size is what going to help us.
Can you explain how do we calculate PCI in ovarian carcinomatosis?
Okay. So PCI in ovarian cancer is basically calculated by looking at first where all the tumor is distributed. We divide the peritoneal cavity into 9 areas by drawing a line, 2 horizontal line, one just under the costal margin and another under the just over the iliac crest. Those are the horizontal lines. The vertical lines are along the mid-clavicular line. So you drop a line along the mid-clavicular line. So those are the landmarks. So this will make 9 quadrants to the abdomen. The center is zone 0. And then you start doing your numbers from the top right. So 1, 2, 3, and then you go down in a clockwise fashion and you finish in the right lower quadrant, right lumbar region. The center is 0. The 4 small bowel areas would be upper abdomen, right and left, and lower abdomen, right and left. Meaning to say you're dividing the small bowel into proximal and distal jejunum, proximal and distal ileum. So these are the 13 different areas. So when the tumor that you're seeing in a particular area, the largest tumor visible in an area is what you're going to score. So when the largest visible tumor is only 5 millimeters or less, the score will be 1. When it's between 5 millimeters to 5 centimeters, it's going to be 2. Anything more than 5 centimeters is going to be 3. So you don't have to go taking a scale and measuring each of the nodule that you're seeing in the peritoneal cavity. We're very good at eyeballing. We know whether something is more than 5 or less than 5. So that itself will help you. So, and then quickly sum up all the scores in all the areas and you'll get the PCI score.
Okay. That's sort of, I think we answered most of the questions from the residents. Thank you so much once again, Dr. Anu, for the excellent cases and patiently answering the innumerable questions from the residents.
Thank you very much.
Yeah. And to all the residents, thank you so much for actively asking and clearing your doubts. And today's last session of the ICRI Women's Imaging recap sessions. And I thank the ICRI team, especially Dr. Varaprasad, Dr. Sikandar, and Dr. Anbarasu for giving me this opportunity to coordinate. And I also like to thank all the faculties who had made wonderful teaching sessions, which made, I hope all the residents benefited with all these lectures and the recap sessions. Thank you once again.
Thank you very much. Bye-bye. Good night.
Thank you, ma'am. Thank you, Dr. Anuradha, ma'am. Excellent cases compiling today. And I think you covered each and every aspect of the pathologies. And most important, all of them were purely exam cases, which residents are needed actually. So thank you, thanks a lot. And thank you, Dr. Rupa, for your coordination, moderation, and everything you have done for making this women's imaging a most, I can't, because you are single-handedly manage everything without any moderator, any other coordinator. So you are combined moderator as coordinator for each and every session and getting all those faculties on board. Thanks a lot. And hopefully we'll be back, you will be back somewhere down the line post June somewhere, because we'll be starting women's imaging in later half of our 2022. So till then, stay tuned. And before concluding, requesting all the residents once again to subscribe for this, because we are very close to 31st of January. After 31st of January, you will not be able to watch our live videos unless and until you subscribe for this new subscription, which is starting from 1st February. And this is one-time payment of 2,000 rupees for residents plus 18% GST, and for faculties and radiologists it is 3,000 plus 18% GST, and it is one-time payment for entire 1 year and for live webinars only, not for RQs. RQs we have already taken separately, and RQs link is also there, which has been circulated. Those who have missed, there is an option of watching a single video, single lecture, or entire women's imaging module or chest radiology module. You can subscribe in that way, and there is a time limit. Most important, please make a note of that. Don't just subscribe it. Please note down whether it is feasible for you or not. Some of the single videos are valid only for 24 hours. So make a note of this and then subscribe for RQs. And tomorrow we are having one more last session of neuroradiology recap sessions by eminent faculties by Dr. Shailesh Gaikwad sir from AIIMS New Delhi and Dr. Hema Pendarkar ma'am from NIMHANS Bangalore. So stay tuned tomorrow. And coming Sunday, our program is more focused on the radiographic techniques, that is positioning, which we have not done till date. So that will be the last Sunday and last one of the last sessions. So all the techniques of chest, skull, and abdomen will be covered, like Schuller's view and sunrise view, how you take the x-rays. That is how will be covered in that. And along with that, one important topic by our Vice Chairman, Dr. Anbarasu, will be giving how the oxy pattern of the exam will be there, and followed by one last MICR will be there on PET and molecular imaging. So these are purely MCQs. So with this, I thank you all, and thank you all attendees, and thank you Team Doctor. Over to you for conclusion.
Thank you, sir. On behalf of ICRI, we thank everyone for being part of this webinar. As a part of webinar team, this is Shweta and Neha signing off. Wishing everyone a very good night. Sir, with your permission, may I end the session, sir?
Please, thank you and good night, everyone.
Thank you.
Thank you.